Hi, my name is Pravin Patil. I'm an associate professor of medicine and director of the cardiovascular disease training program at the Lewis Katz School of Medicine at Temple University. I also serve as course director and faculty for our CVI's annual Updates in Nuclear Cardiology program. I welcome you to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses on cardiovascular disease in the age of COVID-19 and COVID-19 myocarditis. Please note this presentation was recorded on April 17, 2020, and the information is up to date as of that time. At the end of my presentation, you'll see some additional resources and have the opportunity to contact me with any questions should they arise. So let's begin with a pre-COVID era myocarditis case of mine, where a 21-year-old male presented with chest pain, cough, malaise for 3 days. He had subjective fever and shortness of breath for a day. He had an ECG that revealed sinus rhythm at 82 beats per minute with diffuse ST elevation. He had normal biventricular function by echocardiography, and he had no pericardial effusion. He had a peak cardiac troponin of 29, and a cardiac MRI was pursued to further characterize his disease. The suspicion for coronary disease was low given his age, and the cardiac MRI images as shown, the late gadolinium enhancement images in the short axis view here demonstrate normal muscle, that's the black area here in the septum. However, delayed hyperenhancement involving the entire lateral wall. We also did T1 mapping that showed the native T1 relaxation time of that same lateral wall was prolonged. The MRI features were in keeping with myocarditis. Fortunately, his clinical presentation was not consistent with acute decompensation of heart failure or heart failure. We treated him with ibuprofen, and he had outpatient follow-up. He was actually seen by me in a telehealth visit due to the COVID crisis, and fortunately, he's been asymptomatic and he's doing very well. There's a spectrum, though, in myocarditis, and there can be cases as I just showed you, but then the spectrum can extend to the fulminant myocarditis case as well. The AHA put out a scientific statement in January this year that emphasized the recognition and the initial management of fulminant myocarditis. In that, they highlighted the differential diagnoses that are important to consider in inflammatory cardiomyopathies. They range from autoimmune, like sarcoid type inflammatory cardiomyopathies, or even eosinophilic myocarditis. They mentioned briefly the toxic effects that can result in myocarditis. But what I'd like to highlight are the infectious etiologies of inflammatory cardiomyopathies. Whether they be protozoal, fungal, bacterial, or viral, which is what we're going to talk significant about today, it's important to consider all of these in our differential. This may be adenoviruses, enteroviruses, Coxsackie, parvo, influenza, or now coronavirus. So specifically today, I'd like to talk about SARS coronavirus 2. The initial cases of coronavirus disease in 2019, COVID-19, were reported in Wuhan in December of 2019. The rapid worldwide spread to a WHO pandemic status highlights it as a global public health emergency. The pathogen is the SARS coronavirus 2 viral particle. And the clinical course that you might be familiar with is that of cough, fever, and dyspnea. But the more complicated patient may be that with those patients with complicated pneumonias or ARDS, acute respiratory distress syndrome. What you may not be as familiar with are some of the ways that coronavirus can be involved in the heart. The cardiovascular involvement in COVID-19 presentations can be variable. In a paper just recently published by Hendren and colleagues, they highlighted an umbrella term called acute COVID-19 cardiovascular syndrome. This could include acute coronary syndromes like ST elevation MI or non-STEMI, acute myocardial injury without obstructive CAD, arrhythmias, heart failure with or without cardiogenic shock, pericardial effusion with or without tamponade, or even thromboembolic complications as it relates to microvascular thrombosis. Specifically, we're talking about acute myocardial injury today without obstructive CAD. Those patients that may have ST elevation on their ECG, but no evidence of epicardial coronary disease. And what may that represent? It may represent myocarditis, some element of cytokine dysregulation, or even stress cardiomyopathy. Included in here would also be microvascular thrombosis. Because of the normal epicardial coronaries, the microvascular thrombosis risk would introduce an additional factor. These patients with the myocarditis or cytokine-related inflammatory cardiomyopathies may also have crossover to other areas of the cardiovascular syndrome, like developing heart failure with or without cardiogenic shock. And we need to be able to identify when that happens clinically. I like this as a demonstration of the temporal course of COVID infection. The initial period, the viral response period during which there's viral replication, demonstrating also lymphocytopenia, is something that many have called the incubation period of the virus. This could also result in direct myocardial injury. What you may be more familiar with is when patients present with, in the pulmonary phase, with abnormal chest imaging, be it X-ray or CT findings. And this is typically somewhere after that 5-day period. This may be a complication, involve complications of respiratory failure and hypoxia as well. These may also extend into the host response period, which is where I'm particularly concerned as we talk about elevated inflammatory and cardiac biomarkers. It's during this hyperinflammation stage 3 host response period that I suspect the coronavirus myocarditis manifests. So what are some of the proposed mechanisms of injury? I mentioned the direct myocardial injury that may occur with coronavirus, and in electron micrographs, Tavazzi and colleagues demonstrated that coronavirus during its replicated period, where it has a direct effect, can be seen accumulating in the interstitium or in macrophages. However, there's only low-grade inflammation at that period. It's predominantly a viral particle interstitial problem. Contrast that now with the cytokine storm and the hyperinflammatory stage 3 type disease that I described. And this is best described by our critical care colleagues, where cytokine storm is implicated in the effects from coronavirus. And the heart is not excluded. Although I showed you a temporal relationship of these different phases, the viral response and the host response, these things do not happen discretely. In fact, there's probably quite a bit of overlap. The hyperinflammation immunoresponse is probably happening alongside of the respiratory failure and the hypoxemia, probably mediating it to some degree as well. The direct myocardial injury that's happening in our cardiac patients is also probably ongoing to some degree. But what does it manifest? It manifests with biomarker release of injury, arrhythmias, acute coronary syndromes, as well as heart failure presentation. So how do we investigate those? We can do ECGs, we can perform echocardiograms, we can wear ambulatory monitors, and we can draw biomarkers as well as perform imaging studies. So what are we aiming for? We're trying to characterize acute myocardial injury. There are a number of potential etiologies of myocardial injury, and viral myocarditis, as it relates to coronavirus, is only a subset. And the acute myocardial injury may also be related to some degree with the cytokine storm. This elevation in cardiac troponin is sort of the hallmark of characterizing a myocardial injury, and it may be related to other clinical events as well. Stress-induced cardiomyopathy, microvascular thrombotic injury, pre-existing cardiovascular disease. Aortic stenosis doesn't go away when coronavirus is present. Hypoxemia, ventricular arrhythmias, and so on. So if we take the fact that the definition of acute myocardial injury hinges on cardiac biomarkers, it's important now to go back and look at some of the data from Wuhan in terms of a retrospective review of that cohort. And in this study by Zhu, confirmed COVID-19 patients with definitive outcomes, either dead or survival to discharge, were included in analysis. And this amounted to almost 200 patients. They defined acute cardiac injury as elevated cardiac troponin, new EKG findings, or echocardiographic findings. And if you look at the time course of high sensitivity troponin, you can see the exponential rise of troponin in those patients that did not survive. And in those who did survive to discharge, it was essentially flat. If we then take that data and compare it to the D-dimer data that we also use as a biomarker for coronavirus, you can see those same non-survivors had an escalated D-dimer temporally, and they had a flattened response in those who were survivors. Additional data using biomarkers that are evidence of cardiac injury to risk stratify patients is shown by Dr. Shi and colleagues here, also from Wuhan. And you can see that those without any evidence of cardiac injury in this retrospective cohort study of confirmed COVID-19 patients, those without any injury had good survival. And those with evidence of cardiac injury manifest by cardiac biomarkers had worse mortality, nearly 50% survival. They looked at cases without biomarkers excluded, and that was about 60%. So there was 60% of their patients that were actually in this retrospective review that were excluded. 20% of their patients had elevated troponin and when those biomarkers were checked, and these were predominantly older patients and those with other comorbidities. So comorbidities is important as well. So let's talk about the implication of having known cardiovascular disease and combining that with the presence or lack of cardiac troponin. And that's this study here by Guo and colleagues, where they look for presence of myocardial injury in addition to the presence of known cardiovascular disease. And you can see that those patients with known cardiovascular disease and elevated troponin, the mortality was nearly 70%. And those without cardiovascular disease but normal troponin, the mortality was only about 8%. This troponin rise was associated with other biomarkers as well: higher leukocyte counts, lower lymphocyte counts, higher levels of D-dimer, CRP, procalcitonin, and NT-proBNP. So let's take that data on acute myocardial injury as it relates to viral myocarditis and the utility of biomarkers to risk stratify and identify these patients, and look at a couple of reported cases. First, from Italy, a 53-year-old woman presented without any cardiovascular history, severe fatigue for 2 days, no chest pain, no shortness of breath. She had fever and cough for a week prior, and she was COVID-19 positive. The EKG demonstrated ST elevation in the inferior leads, here lead 2, 3, and AVF. She had an X-ray that demonstrated interstitial edema as well. Further data included a CRP that was 1.3, a lymphocyte count of 950, high sensitivity troponin T of 0.24, and an NT-proBNP of 5650. She had no significant epicardial coronary disease on catheterization, and her echocardiogram demonstrates severe diffuse LV hypokinesis, but also LVH with 14 millimeter concentric walls. She had a pericardial effusion on that echocardiogram, and this led to further desire for further myocardial characterization, as I've shown you in other myocarditis suspected cases. So this patient had a CMR. And this demonstrates severe LV systolic dysfunction. This is an SSFP sequence showing a balance of T1 and T2 signals and the cardiac function. You can see there's severe diffuse LV hypokinesis and a circumferential pericardial effusion here in white. T2 images from a dark blood sequence demonstrated increased T2 signal in specific areas of the LV that were consistent with myocardial edema. They also demonstrated late gadolinium enhancement diffusely in the LV myocardium, and this was primarily demonstrated by a lack of ability to null the myocardium. Previously, I showed you a late gadolinium enhanced image where there was a normal area of muscle that was black, essentially. That's nulled myocardium. They were unable to achieve that here and called this diffuse LGE. The clinical course of this patient was that she was supported with IV dobutamine for 4 days. She initiated on guideline-directed medical therapy on day 5. No endomyocardial biopsy was performed, and based on her cardiac MR results, she was placed on hydroxychloroquine 200 milligrams twice daily, lopinavir, ritonavir combination for twice daily, and IV steroid pulse for 3 days. She had follow-up echocardiography study done, which demonstrated a reduction in LV wall thickness to 11 millimeters, implicating that 14 millimeter measurement is likely an interstitial edema type infiltrate of the myocardium, an improvement in her LVEF, and a decrease in her pericardial effusion size. So if you review her temporal course and then reapply that to the temporal course of the virus that I showed you, she presented after a week of pulmonary symptoms, and likely her myocarditis was a manifestation of the hyperinflammation that's typical of stage 3, or the host response. And still, these things were going on concurrently. She had probably some element of direct myocardial injury, but she also had respiratory symptoms as well, and she had an hyperinflammatory status that contributed to her myocarditis, which was acute myocardial injury. How about another case, this time from South Korea, a 21-year-old with fever, productive cough, and shortness of breath. They were COVID-19 positive by nasopharyngeal swab, had a troponin I of 1.26, and an NT-proBNP of nearly 2,000. The X-ray here shows patchy interstitial edema or infiltrates, and her ECG demonstrated ST and T wave abnormalities, but not typical of injury without reciprocal changes. The CT, which has been a key study in terms of risk stratifying these patients, demonstrates significant ground glass opacities in a pattern consistent with coronavirus. Echocardiography in this patient demonstrates severe global LV hypokinesis without evidence of an intramural thrombus, though there was severe LV dysfunction here, shown in the apical 4 chamber, apical long axis, and the apical 2 chamber views. CT angiography was employed in this case to exclude epicardial coronary disease as a player in terms of the rise in troponin. There was no significant epicardial coronary disease in this young woman. An MRI, again employed here to characterize the myocardium, demonstrated significant late gadolinium enhancement, hyperenhancement of the entire lateral wall as it extended apically, as well as in short axis, an involvement of the anterior and inferior walls in an epi to mid myocardial, as well as subendocardial involvement. And I think that was important that they excluded epicardial coronary disease given this pattern. But the extent of late gadolinium enhancement as it extended apically was quite significant. Looking at T2 dark blood images, you could see that there was increased intensity in comparison to skeletal muscle, and this was consistent with myocardial edema. Native T1 mapping showed an increased T1 relaxation time in the myocardium laterally, and this is typical of the studies I've shown you. In this patient, they also did an extracellular volume estimate, and in this case, the extracellular volume percentage was increased, as you might expect with an interstitial infiltrate of myocarditis. So in summary, the presence of myocardial injury is clearly risk stratifying in COVID-19 patients. COVID-19 myocarditis is a subset of myocardial injury, as I showed you, and a working diagnosis can be established by multimodality imaging. And I've tried to demonstrate that as well. This is often an alternative to pursuing endomyocardial biopsy. The exact mechanisms, they're still not yet clear, and the COVID literature is clearly dynamic. As more COVID myocarditis cases arise, we will get a better sense of the mechanism and the response to different therapies. And there'll be a shift from some of the global data that I've shown here to some more of our national data and experience. Making the diagnosis in myocarditis is clearly the key in deciding on appropriate medical therapy or potentially offering mechanical therapy, support therapies to patients that might benefit. And I thank you. Here are several additional resources on COVID-19 myocarditis for your review. If you have any questions for me, please email CVI's Executive Director, Mark Hartnett, at the address shown. And feel free to share this link with anyone who might be interested in the information. And please let us know if there are other topics of interest to you as well. I thank you for watching this CVI Heartbites segment. For more information on other CVI Heartbites segments, as well as other CVI educational programs, please visit us at cviphiladelphia.org or follow us on Twitter. Thank you so much.